Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Meet the Professor. As today we talk about optimizing the management of soft tissue sarcomas and related connective tissue disorders, particularly desmoid tumors. We're so happy today to have Dr. Rich Riedel from the Duke Cancer Institute, the Duke Sarcoma Center in Durham, North Carolina. We had a previous program with Dr. Van Tine in this series. As always, if you have any questions or cases you'd like to run by us, just type them into the chat room and we'll talk about as many of these as we have time. As always, we have a 1-minute pre and post survey for you to take. If you do that, we'll learn a little bit more about you and you'll get more out of this meeting. We do webinars all the time. I'm really looking forward to one this coming Thursday, same time, focusing on HCC, hepatocellular cancer, particularly the interesting idea of two really interesting first-line therapies and now adjuvant therapy for HCC. On July the 31st, we're going to be talking about a really important topic, high-risk hormone-sensitive non-metastatic prostate cancer, particularly the classic or amazing trial that was just presented at AUA by one of our faculty, Dr. Shore, the so-called EMBARK study. That should be very interesting. We talk all the time now about bispecifics. We just did a program on bispecifics and myeloma. Wednesday, August the 2nd, we'll be doing a program on bispecifics, particularly in follicular and diffuse large B-cell lymphoma. Then on August the 8th, we'll talk about new data sets in the management of metastatic pancreatic cancer. And on August the 10th, it's always going to be great to work with Professor Long from Australia. She seems to know everything about melanoma, and there's so much going on there now. If you're into audio programs, check out our Oncology Today podcast series, including a recent program on desmoid tumors with Dr. Gounder from Memorial Sloan Kettering. But today we're going to talk about the broad perspective of sarcomas, and we have three docs who are presenting cases from their practices. Dr. Boy, actually a sarcoma investigator from Stanford. Dr. Hussein down here in South Florida with us, a general medical oncologist who has a particular interest in sarcoma, and Dr. Thomas, who we know from when she was at MD Anderson heading their HCC department. Now she's doing general medical oncology in the Duke satellite situation there, and really great. Here's what we're going to do today. Really, what I really want to do is make rounds with Dr. Riedel. This topic really is just so varied based on the type of tumor. I think the best way to learn about it is case-based learning. I don't know if we'll ever get to beyond that, but we do have a lot of great slides, as always, in the slide set. For if we don't get to them, you ought to check it out, particularly the issue of immunotherapy, but also desmoid tumors, what's going on there, targeted treatment, and there's also an appendix of a whole bunch of other things. But just let me, before we get started, Rich, maybe you could just talk a little bit about your clinical practice and how you got interested in this field. You know, to me, and I think all oncologists, it's a little bit confusing. I'm curious what got you into it.
Well, let me begin first, Neil, by thanking you for having me. It's certainly a pleasure to be here. I've been in the field now for 15 years. My clinical practice is solely focused on patients with soft tissue and bone sarcomas, as well as soft tissue tumors that fall within that realm, like desmoid tumors, for example, tenosynovial giant cell tumor. I got into the field almost by accident. Everything through residency and fellowship that I did was focused on lung cancer, but it turns out when it came time for looking at job opportunities, there was an opportunity at our institution to grow the sarcoma program, which really intrigued me. And the more I learned about the disease, the more I was fascinated about it. And it turned out the only piece that was missing at Duke was a dedicated medical oncologist. So I took a leap of faith, joined the group, and haven't looked back. It's been the best decision that I could have made.
So, yeah, I'm really curious to hear more about what that's like, but let's talk about some patients now to get started. And of course, in oncology in general, you mentioned you were interested initially in lung cancer. So certainly we talk about checkpoint inhibitors all the time in lung cancer, but not so much in sarcomas, except one scenario, alveolar cell sarcoma, soft tissue sarcoma. And we actually have a case from Dr. Boyd, and actually Dr. Hussein had some questions about this. So we actually have an approval. This is a patient who has a recurrent disease, has gotten multiple VEGF TKIs, mainly on trials, got a single agent PD-1 inhibitor on trial, And actually, he's been on, interestingly, a combination of axitinib pembro for 3 years with stable disease. Here's Dr. Boy.
28-year-old female with right ankle pain and swelling started in late 2018. She had an MRI done, which showed a 5.9 centimeter mass behind her tibia, as well as multiple other nodules. PET CT and CT chest showed innumerable pulmonary nodules measuring up to 1.3 centimeters in size. The CT abdomen and pelvis showed numerous hepatic mets measuring up to 3 centimeters. Actually did enroll in the VEGF TKI clinical trial. No response, but stable disease for 6 months, then progressed. So we did start her on the immunotherapy with a single agent PD-1 inhibitor per the trial. And she had surgery of the largest leg mass in the right leg. She unfortunately progressed not that long after, like a month after, with enlarging hepatic and pulmonary masses. So this is an unfortunate case of a patient who doesn't respond that well.
Anything else you want to bring up?
Yeah, so I think for ASPS, the question is, do we use chemotherapy? In new diagnosis ASPS patient, would you start with a VEGF inhibitor? Would you start with immunotherapy? Or would you start with a combination VEGF TKI plus immunotherapy?
We ran the phase 2 trial of atezolizumab, and it's really amazing that immune therapy has not really worked very well in sarcomas, but it seems in this type of sarcoma, it definitely showed very decent overall response rate. My question is, what's unique about this type of sarcoma, and how are we going to build on this atezo success story? Would we add chemotherapy like we do in almost all cancers now? Something like doxorubicin.
So lots of questions there. I'll throw in, what about earlier stage disease, neoadjuvant, adjuvant, TKI, IO, both, et cetera? Any thoughts?
I think they're all great questions, and my hope is that many of which can be answered in the context of future clinical trials. I don't think we have a full understanding as to why immunotherapy works in ASPS. We know from some initial work that was done by Dr. Breland Wilkie in Colorado. In fact, when she was at Miami, she ran the trial of axitinib and pembrolizumab. She then moved to Colorado. But in that study, a number of the responses were specifically seen in ASPS. And we have known for quite some time, largely from some work done at the NCI, that these multi-targeted TKIs, VEGF receptor inhibitors, have activity. Began with cediranib, then sunitinib. There's some data for pazopanib. But the combination together, it's unclear to me if the combination works better than either one alone. We have single-agent TKI studies, we have single-agent atezo study, and then we have the phase 2 combination with axitinib and pembrolizumab. At least in my practice, now with the approval of atezolizumab would be my first-line therapy. I would give it as a single agent, in part because the treatment options are somewhat limited, and I'd rather use sequential therapy to expand the number of weapons that I have available than sort of using two things at the same time. In the case that Dr. Bowie presented, somewhat interesting that they had gone through both single-agent immunotherapy as well as TKI, and it was only with the combination that they were able to get some degree of stability. So I think those are all some unanswered questions. I think certainly the concept of neoadjuvant therapy is attractive, and I suspect will be studied in some form. It's also important to note that for this particular disease, there is a wide range in terms of clinical behavior. Patients can live up to 10 years with low-volume indolent lung metastases that don't require any treatment. In contrast, there are individuals who can have rapidly progressive disease, which sounds like was the case with Dr. Bowie's patient. But certainly excited that both the use of TKI as well as immunotherapy can be used in this disease. To answer Dr. Hussein's question, we do not routinely use, or I'll say for myself, I do not routinely use conventional cytotoxic chemotherapy in this disease state. It just does not work.
So I know that ASPS is thought to be a vascular tumor. I guess that's kind of the tie-in to the TKIs. Any thoughts about why you might see synergy? I mean, of course, you hear this renal cells and other situation between an anti-angiogenic and IO.
I wish I knew the answer to that. It's not clear to me that we have a full understanding of that. There's a lot of interest in ASPS. It is defined by a very characteristic translocation, and there's a lot of work trying to understand how that plays a role in the pathogenesis. But as to why the combination or why either either of those groups of therapies work, it's still a little bit unclear. We can invoke the vascular nature of the disease state as to why VEGF receptor inhibition may work, but for other vascular tumors, we've seen that that those sorts of therapies perhaps don't work. So it's still a little bit of a black box.
So let's go into another case and kind of continuing this theme of IOs. Dr. Thomas has a 66-year-old man with a dedifferentiated chondrosarcoma. Anyhow, here's the case. I'm curious what you think about it. This patient actually ended up getting PD-1 pembrolizumab maintenance after chemotherapy.
Right knee pain. He got a good imaging workup really right away that showed both kind of a chondroid lesion in the bone with this adjacent, quote, soft tissue component with a pathologic fracture. He underwent this extensive resection, 13-centimeter dedifferentiated chondrosarcoma, PD-L1 2+, somewhat unusual for sarcomas. We received 4 cycles of doxorubicin and cisplatin, and now he's on this pembrolizumab as maintenance. So this was a recommendation from our sarcoma specialist. So the main question I would have for the sarcoma specialist is how long would they continue the pembrolizumab? You know, we really don't have any level 1 evidence in the sarcomas.
Any other questions?
You know, I find them such a challenging group of tumors. They're all so different. They have these strange behaviors sometimes. I would love to know from the specialist is where do they feel the field is going as far as understanding the biology, if not of all sarcomas, because they are so heterogeneous, but of some of the more common ones, these liposarcomas. I feel like we give these patients the traditional regimens, and at best, they may slow them down, but I don't feel like we've made a lot of progress.
So I don't know whether you share her frustration. I'm sure to some extent you do. Before you get into that, can you let's talk a little bit about chondrosarcoma, the biology, clinical presentation, and what you think about this case?
Well, this is an interesting case. It's a dedifferentiated chondrosarcoma. Most chondrosarcomas are of the conventional subtype, and the conventional chondrosarcomas are basically a surgically treated disease. There is no approved systemic therapy. Dedifferentiated chondrosarcoma, at least guidelines currently recommend that they be treated in a similar fashion to osteosarcoma, which is why Dr. Thomas used cisplatin and doxorubicin. So I applaud her approach from a conventional chemotherapy standpoint. The use of pembrolizumab as maintenance therapy is interesting. As she correctly points out, we don't have evidence to support that. I probably, if this patient were at our institution, I probably would have stopped after the chemotherapy and watched. And I don't think we have data currently that PD-L1 by IHC is predictive of response to immunotherapy. I'm a little surprised that she was able to get it paid for, to be quite honest. But if it works and or provides benefit, then I think that's great for the patient. In terms of how long to continue it, I don't think we know the answer to that. A lot of times we will extrapolate from our colleagues in melanoma. We'll treat to best response and typically stop at 2 years, for example, but I don't think we know. I think the concept of maintenance therapy in sarcoma is something that has been explored in soft tissue sarcoma years ago, looking at mTOR inhibition as part of the SUCCEED study. The SUCCEED study, though, was a failure and did not confirm the benefit of maintenance therapy. Hard to know in this world of checkpoint inhibition whether or not that's going to play a meaningful role or not in this case, but time will tell.
I just actually noticed that this patient had an IDH2 mutation. You know, we saw IDH inhibitors first coming into AML, now biliary tract cancers. Do you see this in any sarcomas? Do IDH inhibitors work in those patients?
We see IDH mutations in chondrosarcoma. In fact, I would be more enthusiastic about an IDH inhibitor than I would about checkpoint inhibition. In fact, in NCCN, they do have compendia listed IDH inhibitor for those with mutations. So I think that is certainly an option that can be considered with subsequent lines of therapy upon progression.
So you'll have to pass that on to Dr. Thomas. Before you get into her more general question, just kind of curious, I always seem like I'm asking this all the time. about the chemotherapy shortage that's going on right now. To what extent has that affected you at Duke? Are you getting questions from people in practice about it, and what are you doing?
It's currently affecting our patients who require cisplatin as well as patients with methotrexate. Both of those agents are used in patients with osteosarcoma. So it has been a challenge. At least 2 patients come to mind currently who I am treating with curative intent MAP chemotherapy, both of which use methotrexate and cisplatin. And so we have some medication stockpiled. Duke is, and I'm sure other academic institutions are looking at alternative sources. Our institution has required stoppage dose limits. So instead of 12 grams per meter squared of methotrexate, which is standard, we're mandated to stop at 8. So we're trying to be somewhat strategic and share the limited supply, but it has been a challenge.
What about Dr. Thomas's questions about just her frustration with the lack of what she perceives to be progress? Anything exciting or encouraging you can say to get her a little bit more interested or optimistic?
I think she's articulated the frustration that many of us in the sarcoma field have felt for many years. We've had a lot of clinical trials. We've tried a lot of combinations, for example, to try to improve over single-agent doxorubicin for frontline metastatic disease without success. But we are starting to move the needle, and I think we've been challenged in the past in part because the way we designed our clinical trials. We would allow any soft tissue sarcoma to enroll, and that we now know encompasses more than 150 different histologic subtypes. We're being smarter now. We're doing molecularly driven studies. We're doing histologic specific studies. And in the last 5 years or so, we've had at least 4 or 5 FDA approvals with that strategy. So we are moving the needle, albeit slowly, but I think there's a lot of enthusiasm in the sarcoma field currently for what's going on. But I do share Dr. Thomas's frustration.
So speaking of genomic assays, I'm curious, have you seen any patients who had NTRK fusions? Have you used any NTRK inhibitors with sarcomas?
We look a lot, and we don't find many. I would say in the last several years that we've been actively looking, I can remember 1 patient. I think the statistics, when they first discussed the use of NTRK inhibitions in cancers as a whole, the statistics were that sarcoma was somewhere between 5 and 8%. I think that's now dropped to 1%, but at least in my looking, it's less than that. When you see it, though, it's a home run because there can be durable responses. So we will keep looking, but it's like finding a needle in a haystack.
What happened to your patient? Did you give did the patient get an NTRK inhibitor, or did they respond?
They did. They had a durable response for approximately 10 months or so, but then subsequently progressed.
Which agent did they get?
This was in the context of a clinical trial study in entrectinib.
So sometimes people in the chat room ask questions. I'm not even sure what they're talking about, but I figure they know more than me. So Tisvedin says, is the unsuccessful milademetan PH3 in dedifferentiated liposarcoma now a red flag for other MDM2 inhibitors? And I'll add, what are MDM2 inhibitors?
So milademetan is a novel inhibitor of MDM2 that was studied in liposarcoma as part of the phase 3 RAIN study, RAIN. We've seen top-line data informing the sarcoma community that it was a negative study, which was disappointing. This was a study comparing milademetan to trabectedin, which is FDA approved currently in liposarcoma. We haven't seen the data. It's hard to know or to speculate as to why it was a negative study. I certainly do not think that it puts the kibosh, if you will, on other MDM2 inhibitors. I think we need to delve into the data that's available, understand where the potential confounders may be. There may have been some statistical assumptions that were flawed. It's hard to know without seeing the actual data, but certainly disappointing that at least the first foray into MDM2 inhibition was unsuccessful.
So here's a case from the chat room. This is Dr. Malady, a general medical oncologist. What would you consider as treatment for a solitary fibrous metastatic tumor? I guess a fibrosarcoma, a resectable, large volume disease and symptomatic. Would your option be chemo like dacarbazine based or TKI like pazopanib?
It's a great question. So solitary fibrous tumor is different than fibrosarcoma. Those are two different histologic subtypes. But solitary fibrous tumor is another mesenchymal neoplasm. There are different variants, including a dedifferentiated subtype, a more typical SFT is what we call them. But what we have learned is that SFTs, at least the classic teaching, was that conventional chemotherapy did not work for that disease, for this disease. That has been called into question in recent years with some work done by our Italian colleagues to suggest that there is some minor activity for dacarbazine, for example, or anthracycline-based therapy. But I would say that most in the sarcoma community would start with an anti-angiogenic agent, such as pazopanib, or the combination of bevacizumab in combination with temozolomide. I routinely, in my practice, would start with pazopanib. It's never been compared to bevacizumab and temozolomide, but certainly from a convenience standpoint, being an oral therapy, that is what we would start with. I'll clarify. Yeah, I'll just clarify, for a dedifferentiated solitary fibrous tumor, we will use conventional chemotherapy in that disease state. But for a typical SFT solitary fibrous tumor, I would go with pazopanib.
So hats off to the general medical oncologists. I don't know how they do it and keep up. SFT, I haven't heard that one before. As long as they're trying to cheer Dr. Thomas up, what about, other forms of immune therapy, CAR T, bispecifics? As mentioned, we're doing all this stuff in bispecific. Anything happening there? Antibody drug conjugates? Any of the things we're hearing about in oncology you see coming into sarcomas?
Right. I would say the sarcoma field as a whole is probably 5 to 10 years behind where the more common disease states are. So we are just starting to see trials looking at antibody drug conjugates. Probably the highest degree of enthusiasm currently centers around the use of engineered T cells or SPEAR T cells, specifically in synovial sarcoma and in myxoid round cell liposarcoma. Those two entities will express tumor antigens, neoantigens, NY-ESO, as well as MAGE-A4. And so those are attractive targets for those sorts of strategies. And we have studies now that are being presented at meetings and hopefully soon to be published that have showing proof of principle and showing responses. So I think there's quite a bit of enthusiasm around that strategy in select histologic subtypes.
All right. Well, I think this next section should be of interest and also hope in general to this field. Of course, it's a little bit outside of what we've been talking about because we're about to talk about desmoid tumors. And before you hear about this case, I'm just sort of curious what you'd be thinking if you knew there was a 30-year-old man coming into the clinic who's asymptomatic, has, quote, a bulge on the abdomen and a 6.2 centimeter palpable mass that's proven to be desmoid fibromatosis. And you're seeing the second opinion, but the first opinion says surgery. Well,
so the initial question that would come to mind, at least for me, in a 30-year-old with an abdominal desmoid, is it a mesenteric intra-abdominal desmoid tumor or is it abdominal wall? And the reason why that's important is because if it's mesenteric or intra-abdominal, I would think about an FAP-associated desmoid, and the patient would require a colonoscopy given the risk for colon cancer. Assuming it is a sporadic desmoid tumor or known to be associated with a beta-catenin mutation, so non-FAP associated, I would say that when I hear surgery, it causes pause. Our treatment paradigm for desmoid tumors has changed in the last 5 years or so, where we have actually moved away from surgery for desmoid tumors. And now the first choice is actually observation, imaging surveillance alone, in part because there can be spontaneous regressions. These tumors can wax and wane over time. They can spontaneously regress on their own. So these are not malignancies. They do not have metastatic potential. It is not typically thought to be a disease that will be life-limiting. And so observation is actually the preferred initial management for patients with desmoid tumors.
So I imagine this patient was very happy that he sought a second opinion. Here's the case.
This is a 30-year-old man. He noted a bulge in his abdomen, April 2021. CT abdomen pelvis showed a 6.2 centimeter mass. A biopsy showed desmoid fibromatosis. APC germline testing was negative. The local team recommended surgical resection with bowel resection to get this tumor out. He didn't want to have his bowel resected. He's a young, healthy guy who likes exercising and eating good foods. So he had a second opinion at a tertiary center where we recommended actually upfront observation as the patient was asymptomatic. You start on observation and the tumor has spontaneously regressed on the current scan nearly 2 years later. That is the original tumor, and then there it is now.
So what are the questions you think would be interesting to discuss about this?
Yeah, so, we can't observe everybody because some patients are going to grow. And so if the tumor were to grow, what therapies are available? If surgery will be morbid, like if it's next to the brachial plexus or some other nerve where they may have to sacrifice a nerve, then we may consider non-invasive local procedures such as cryoablation or HIFU, which is high frequency ultrasound.
Any thoughts?
Well, I would say Dr. Bowie knows exactly what he's talking about. There are, I completely agree. So if you find yourself in a situation where you need to consider treatment for an individual, systemic therapy really is the first choice over surgery. I think the one situation in which surgery is still considered for desmoids is for a small abdominal wall desmoid tumor where the morbidity is expected to be minimal. In the absence of that, it's observation and then typically consideration for medical therapy. From a medical therapy standpoint, there are a number of potential options. Sorafenib, not FDA approved, but NCCN compendia listed. That's based initially on a single institution study from Memorial Sloan Kettering that then turned into a phase 3 study published in the New England Journal, showing a response rate of 33%. What was interesting about that study, though, was that there was a placebo arm, and the placebo arm showed a response rate of 20%. Again, speaking to the fact why observation is preferred. But I think sorafenib is certainly a reasonable treatment option. For mesenteric desmoids, if they are growing, I will often jump to an anthracycline-based regimen and consider a regimen of doxorubicin in combination with dacarbazine. There is retrospective data saying that response rates for anthracycline-based regimens can approach 50%. So I get a little concerned if I have a growing and or symptomatic mesenteric desmoid, and I will often start with an anthracycline, but certainly sorafenib or an anthracycline would be my first two choices for currently available therapies. And then lastly, for Dr. Bowie's question, Bowie's question about locally invasive local therapies. Certainly, radiation therapy can be considered. Radiation can control desmoid tumors, although in a 40-year-old who's dealing with a non-life-threatening disease, my enthusiasm for that would be lower given the risk for secondary malignancy. Cryoablation is certainly an option. In some centers, such as Stanford, HIFU can be considered. At least at our center at Duke, we will routinely consider cryoablation for desmoids in easily accessible locations for which morbidity would be limited.
I was just going to say that one of my favorite graphics of all time in oncology is the waterfall plot of the placebo arm of the sorafenib. That was a pretty good waterfall plot. The placebo really works well. But anyhow, what a case when you see it. We had another case like this with Dr. Van Tine. You were talking before about the biology of desmoid, whether it's based on a patient with FAP or not. This next case is a patient with FAP. Before I get into it, could you just go back in terms of what the difference is in terms of sort of biologically?
So both beta-catenin and APC are involved in proliferative signaling. And in normal cellular processes, APC and beta-catenin complex together in combination with some other proteins. That joining, if you will, results in phosphorylation of beta-catenin and ultimate degradation. In desmoid tumors, though, you can have beta-catenin mutations. You can also have APC mutations. And in either case, the presence of the mutations in either gene prevent that binding and prevent the degradation, if you will, of beta-catenin. With it not being degraded, it then translocates into the nucleus and then results in proliferation. So that's why the Wnt signaling pathway, at least recently, has been thought to play a role, and as a result, also Notch signaling. The Notch and Wnt signaling pathway have quite a bit of crosstalk, and in fact, in clinical trials, there is ongoing efforts looking at what are called gamma secretase inhibitors, which prevent the intracellular signaling of Notch, prevent the cleavage of Notch, resulting in the intracellular movement of Notch to drive proliferation. And gamma secretase inhibitors now are being looked at in desmoid tumors. And in fact, nirogacestat is a study, an agent that was just published in the New England Journal showing promising activity.
And we're going to talk about that in a second. But let's get into this next case. This is a patient with FAP, and interestingly, she had a surgical excision of 3 simultaneous colon cancers followed by adjuvant capecitabine. And on follow-up, she's found to have a rapidly enlarging mass, but in fact, this turns out to be a desmoid. Here's Dr. Bowie.
This is another desmoid patient, a 40-year-old female with history of FAP. She had a colectomy for multiple primary colorectal cancers. About a year later, found a rapidly enlarging tumor, which is eventually found to be a desmoid tumor, abutting the iliac and mesenteric vessels. We started her on chemotherapy because she had just massively progressive disease, had a great response after 6 cycles. After she maxed out on that therapy, we switched her to sorafenib, and she continues with a great response. So if you look at her scans, it's pretty amazing. This was when they first saw it after colorectal cancer surgery. So they thought maybe she had colorectal recurrence. So this is prior to her biopsies. That was what it looked like. Look at it like then. 4 months, look how giant it is. It's her entire abdomen. If she came in complaining that it felt like she was pregnant with a huge belly, and it was all desmoid tumor, basically filling up her abdomen. So we treated her with chemo. After 4 cycles, it shrunk down some. You can actually see her spleen and her liver and her intestines now. That's after 1 year of sorafenib.
What are the questions you have about this case?
So is chemotherapy used in desmoid tumor? There's another question about can surgery stimulate desmoid tumor growth? There's actually a new agent, the gamma secretase inhibitors, nirogacestat. In retrospect, if you had this drug a few years ago, would I have done nirogacestat? A patient of mine I know was on MS Contin, Norco every 6 hours. Within 3 weeks, she was off all her pain meds. And the tumor hadn't really shrank all that much. So I think even if this tumor isn't shrinking, it can really improve symptoms. Based on the clinical data of the recently published phase 2 trial, if this will be the first line option for patients with symptomatic tumors. Or should we use it neoadjuvantly? Should we try to take patients to surgery eventually? Or should we just leave them on nirogacestat? And also another question is, how long do you have to treat patients with nirogacestat for? Can they stop it after a year? And then another important question was that there is a risk of ovarian failure with nirogacestat.
So do you feel like you're on rounds and everybody's throwing a million questions at you, except it's really only one person?
There's certainly a lot of information there. But this is I have seen this in practice as well. These FAP-associated mesenteric desmoids can be very aggressive. And I completely agree with Dr. Bowie's initial approach of considering an anthracycline doublet, doxorubicin in combination with dacarbazine. I would have done the same thing here. It looks like they had modest response, but had some pretty significant improvement in symptoms. We do see that. So the tumors don't need to shrink to have symptomatic improvement. They then followed with consolidation sorafenib, and it sounds like the patient is doing quite well. So certainly happy to hear that. In the context of nirogacestat, I think nirogacestat, should it be FDA approved as the first gamma secretase inhibitor to be approved, I think that certainly will likely become a preferred agent. As Dr. Bowie pointed out, ovarian dysfunction is something that we need to be mindful of, particularly for our women of childbearing potential. That in and of itself wouldn't preclude me from considering it in a male, for example.
So we'll do one more case of desmoid. I don't know. I just find this so fascinating, particularly the recent nirogacestat story and the fact that there was a advocacy group that was really involved in getting the DeFi trial going to get nirogacestat. I remember when I sat down a couple of months ago with Dr. Gounder, and I was like, we're scheduled to talk for an hour and 45 minutes. I'm like, what are we going to talk about? And after an hour and 45 minutes, we were still going. So anyhow, I just find it fascinating. Let's hear one more case. This is back to Dr. Hussein, who's got a 36-year-old man. Here's the case.
Very nice. 36-year-old man. For a couple of years, his wife will tell him that your posture is not normal. You are tilting towards one side. And they really didn't know why. And after a long time, the wife could see a mass protruding from his back. Biopsy showed desmoid, the tumor huge. By the MRI, it showed a 12-13 centimeter by 6-7 centimeter. We started him on sorafenib, stabilization of the disease. And then after that, it increased in size and he started having some symptoms in terms of pain. He started on liposomal doxorubicin. He received a total of 9 cycles with good cardiac function. My questions to the faculty here, what is the real role of liposomal doxorubicin? Is it considered a second line? What happened radiologically, Neil? although the mass didn't shrink a lot, there was absolute necrosis to my real surprise. This is low-grade tumor. The whole density of the tumor changed. I mean, the pain went away, and he is now with 3 years without a progression of disease, doing very well. My second question is, if God forbid he progresses, what would be the role of nirogacestat if and when he progresses? And what experience do you have using this agent? And what are the most common side effects that can be encountered?
Any thoughts about this one? Have you heard this story about tilting to the one side?
We've heard variations on the theme, if you will. So yes, we have patients who present with large masses on their backs, abdominal walls, extremities. The stories are varied, but presentations can be somewhat similar. Dr. Hussein very nicely again considered sorafenib, also considered liposomal doxorubicin, which is certainly something that we routinely will consider in clinical practice. I think if nirogacestat as a gamma secretase inhibitor gets approved, again, I think that will likely become a frontline and/or preferred therapy, given that it will be the only FDA-approved agent. But I think certainly there's a role for liposomal doxorubicin. As the imaging showed quite strikingly, there was a decreased size in the tumor mass, but also what is characteristically seen with desmoid tumors is a decrease in T2 signal activity. So the white, if you will, the whiteness of the tumor, the enhancement of the tumor actually gets markedly improved, and these tumors can become hypoattenuated or low signal activity. And that's typically inactive disease. So we see that routinely on MRI imaging. If the patient were to progress again, and if nirogacestat were a potential option, I think certainly it would be something to consider. The side effect profile, at least as reported in the New England Journal of Medicine paper, was very reasonable, very few grade 3 or grade 4 adverse events. Hypophosphatemia comes to mind, but in my experience, that is easily addressed with replacement therapy. So I think certainly nirogacestat is a reasonable option to consider should it be approved. There are some unanswered questions. How long do you continue it for? If you stop it and the tumor grows, can you reestablish disease control? These are unanswered questions, but I think answers that will come over the coming years as we get used to the drug and sort of build clinical experience with it.
What about the issue of ovarian dysfunction? I know a lot of these patients are younger women. Are there any fertility preservation strategy? Would you use an LHRH agonist like you do with chemotherapy? What do you see? And does this reverse when you stop the drug?
Yeah, great questions, Neil. In the paper, the term ovarian dysfunction actually referred to a myriad of terms, including things like menopausal symptoms, hormonal blood level abnormalities, for example. And so it was a sort of a constellation of signs and symptoms to go into this grab bag of ovarian dysfunction. So I think we need more data. We need more information. It was somewhat reassuring in the data that's been presented publicly that for individuals who discontinued nirogacestat in the setting of ovarian dysfunction, 100% regained ovarian function. There were a proportion of patients who continued on nirogacestat who did regain function, but for those who did continue, there was also a proportion, the number is escaping me, but I think perhaps a quarter of patients who continued on therapy in whom they did not regain function. So I think we're going to need to think about this more, get some more data, get certainly input from our OB-GYN colleagues on strategies to consider. I think RH therapy certainly can be considered. I'm not sure we have any data whatsoever with the use of nirogacestat, but certainly in conventional chemotherapy, we do that routinely.
So Joseph in the chat room wants to know about, there's commenting on a new ICD-10 code for desmoid tumors. Is this relevant and important? Know anything about that?
Currently, the ICD-10 code that is used for desmoid tumors is D48.1, which is neoplasm of uncertain behavior. It's sort of a grab bag. I think there is a new ICD-10 code that will be coming for desmoid tumors, which I think certainly could help with reimbursement strategies should nirogacestat, for example, get FDA approved.
Interesting. So let's go into another case. This really surprised me when I heard about it. And then I go look up CDK inhibitors in sarcomas. Here it is, 56-year-old man, a patient of Dr. Thomas.
He's got some large mediastinal lymph nodes, a few small lung metastases, and a quite large, probably about 25 centimeter right anterior chest wall and axillary mass. He's asymptomatic from it. He works full time, but he's had a very slowly progressive tumor. This is a patient where next-gen sequencing was actually very helpful. Interestingly, it did show the CDK4 amplification. So actually, it's 2 years ago now, I started him on palbociclib, essentially a breast cancer regimen. I did not add the hormone therapy. So he's been on the palbociclib for 2 years now. Unfortunately, on recent scans, it's progressing. I feel as though the palbociclib has been keeping it under control because the rate of progression has been much more indolent, much slower than on all the cytotoxic regimens. I had two questions. One, would they repeat the next-gen sequencing now? And then some thoughts on what systemic therapy options might still remain.
So any thoughts? I don't know that maybe the audience can correct me, but that you actually see CD4 amplification in breast cancer, but I guess this patient had it. How often do you see this with soft tissue sarcomas? Which ones? And do you ever use the CDK inhibitor outside a trial? I know there's a big trial going on with Abema.
Well, we do see CDK4 amplification specifically in liposarcomas. We also see MDM2 amplification, which is in part why there's a lot of enthusiasm about both MDM2 inhibitors as well as CDK4/6 inhibition in liposarcoma. So it doesn't surprise me per se that amplification was seen on next generation sequencing. In fact, palbociclib is NCCN compendia listed, not FDA approved, but NCCN compendia listed specifically for well-differentiated, dedifferentiated liposarcoma. That's based on some data from Mark Dixon and colleagues at Memorial Sloan Kettering, where they were able to see modest response, but largely stable disease, which would go along with what Dr. Thomas's experience has been for this particular patient. I am not aware what other therapies the patient has had, but I assume that they've had an anthracycline-based regimen, perhaps a gemcitabine-based regimen. But other things that could be considered include eribulin, FDA approved for liposarcoma, trabectedin, FDA approved for liposarcoma, dacarbazine as a single agent we will routinely consider. The one agent that we use for other soft tissue sarcomas that we do not use, though, for liposarcomas are the multi-targeted TKIs, pazopanib, for example. We do not use those in liposarcoma. Both pazopanib and regorafenib have been studied and have not been shown to be beneficial. But I think there's certainly an emerging role for CDK4 inhibitors in liposarcoma, and I think the future may actually hold looking at the combination of perhaps conventional chemotherapy with CDK4 inhibition, but time will tell.
And Durham in the chat room brings up the issue of Abema because there are data in breast with Abema without endocrine therapy. And as we were saying, there's actually amazingly a phase 3 trial of abemaciclib that's actually going on. All right, let's go to another case as a patient for Dr. Hussein, a 68-year-old man.
This is a 68-year-old man who for the last 6 to 9 months has been complaining of abdominal pain and weight loss of around 10 pounds. CT scan showed a 19 by 12 centimeter retroperitoneal mass. 1 week ago, he had a biopsy and I just got the pathology. The pathology shows metastatic high-grade myxoid liposarcoma. He's seen the surgeon. He's definitely unresectable, probably never really resectable because of the involvement of so many veins and arteries in the retroperitoneum. My question to the faculty, would you offer this patient trabectedin rather than doxorubicin-based chemotherapy as first-line treatment?
Any other questions?
I've been waiting to find one patient with sarcoma that's MSI unstable or mismatch repair deficient. Has anybody seen a patient with sarcoma that is MSI high or mismatch repair deficient patient?
So another thing we're always looking for, and a lot of times we do find, but I'm not sure about in sarcomas. You ever seen MSI high?
I wish I did. We do not see MSI. I have not seen MSI high or mismatch repair deficiency in sarcoma. That in and of itself, though, does not preclude the use of immunotherapy in select subtypes. For example, pembrolizumab is NCCN compendia listed, as well as ipilimumab and nivolumab, specifically in undifferentiated pleomorphic sarcoma. So that's independent of MSI status. But certainly if you do find an MSI high or mismatch repair deficient sarcoma, then you have carte blanche to consider those therapies. With respect to the myxoid...
Go ahead.
With respect to the myxoid liposarcoma question, trabectedin currently is FDA approved for liposarcoma after receipt of an anthracycline. That being said, in my practice, I routinely will consider an anthracycline and then I will consider trabectedin in the second line for myxoid liposarcoma, whereas other liposarcoma such as D. diff liposarcoma, I would consider trabectedin perhaps third line. But I will move trabectedin up. I'm not sure I would use it in the front line. The reason why Dr. Hussain asked that question, though, is that there is quite a bit of evidence to show response, preferential response or differential response for myxoid liposarcomas with trabectedin. But I'm not sure that I would use it in the front line. There is data that has looked at the combination of doxorubicin and trabectedin. That might be something to consider. But if this patient needed a response, I would probably start with doxorubicin, dacarbazine, doxorubicin ifosfamide, for example, and then consider trabectedin second line. But there may be others in my community that would disagree with that.
So kind of an amusing comment in the chat room by mistake, getting back to CDK. A doc says that a patient who responded very well to Pablo. I think that was Palbo. Anyhow, and then Sylvestin is asking about selinexor and liposarcoma. Is it approved?
Selinexor is not approved in sarcoma. There was a study. The study published in JCO. It was a statistically, I think, a positive study based on p-value. But when you look at the absolute benefit, it was. I think many would argue that the benefit seen was not clinically meaningful with respect to PFS.
So let's get back to Dr. I'm sorry. Go ahead.
I was just going to briefly say selinexor is an XPO1 inhibitor. It's a SINE inhibitor approved in, I'm going to get this wrong, perhaps myeloma, I believe.
Yeah, myeloma and diffuse large B-cell, last I looked. But I'm not too sure how often it gets given because it's not necessarily that well tolerated, but interesting mechanism of action anyhow.
Absolutely.
All right, let's get back to Dr. Hussain. Dr. Hussain is a general medical oncologist in a big hospital close to us down here in Miami. He's actually in Broward County, and he is about to present this 58-year-old woman. But I thought his comment, I left it in the video, about being a doc in your own hospital, taking care of your own colleagues. Here's his case.
Let me present this patient. This is also, I don't know why. I mean, I'm scared to walk in the hallways of the hospital now because, I mean, it's like half of the employees, I take care of them. It's scary. This is actually 58-year-old. She's in administration in our hospital. 3 years ago, was found on a routine CT scan for possible renal colic to have a mass in the retroperitoneum. Completely asymptomatic from it, around 5 centimeters. The patient went to see a surgeon. The surgeon thought this is a benign tumor. He did surgery where he removed the tumor in bits and pieces. And unfortunately, it turned out to be grade 2 leiomyosarcoma, but we could not really evaluate margins. I had a long discussion with the patient, and I gave her adjuvant doxorubicin based with ifosfamide, and we followed her over the last 3 years. 3 months ago, on a surveillance CT scan, she was found to have a 4 centimeter mass in the same location. This time she went to surgery. We knew what it was, and it was resected where fiduciary clips were placed, and we were able to give her some targeted radiation to that area. We know her risk of recurrence, unfortunately, is still high. We don't know if the initial adjuvant chemo worked, although 3 years, wasn't bad. Would anybody discuss adjuvant chemotherapy with this patient after a recurrence, resection, and radiation? And if yes, what would you give her?
Any thoughts? And have you heard this bits and pieces story before?
Unfortunately, we have. And this is an unfortunate and difficult situation to treat, in part because you never want to remove a sarcoma piecemeal. All it does is sort of contaminate the entire field, which in this case is the abdominal cavity. And so the entire abdominal cavity is at risk for recurrence. Sounds like in this situation, they gave adjuvant chemotherapy. As you may be aware, the use of adjuvant chemotherapy for resected disease, I would say, with an appropriate oncologic procedure is controversial. This situation is a little bit different, though, by virtue of the fact that it was removed piecemeal. The patient had a disease-free interval for approximately 3 years and then developed a local recurrence and then treated aggressively with surgery and radiation. Obviously, the recurrence rate is high, and I think certainly there will be a proportion of colleagues in the sarcoma community that would consider therapy. I would take a different stance. I would take a step back and watch. I'd like to have something to follow if I'm going to expose someone to systemic therapy. So I would sit back and watch at this point. I would image every 2 to 3 months. And when or if they declare themselves, if the time interval is short, I would then initiate systemic therapy. Options at that point, in my opinion, include gemcitabine in combination with docetaxel, for example. Trabectedin, FDA approved for leiomyosarcoma based on a progression-free survival benefit. Single agent dacarbazine, although I would choose trabectedin over dacarbazine. Based on the head-to-head comparison phase 3 study. Pazopanib certainly is an option as well, and certainly clinical trial consideration. So I think a number of potential options, but in the setting of the patient being rendered disease-free, I would be inclined to step back and watch.
So there's 2 great giant cell cases in the chat room. I don't know if we're going to get to them. It's probably not even relevant, but let's do another quick case. Actually, Toy in the chat room asked the same question that Dr. Boy asked about the 61-year-old woman, which is, what's the preferred first-line regimen for leiomyosarcoma? Here's the case.
61-year-old female came to the ER with shortness of breath, found to have a mediastinal mass. With mediastinal mass in the ER, I think it's lymphoma, but they actually biopsied and actually showed leiomyosarcoma. It was not a surgical candidate because this tumor was touching all critical vessels in the mediastinum. You can see on the PET scan. It was just touching every single major organ, like heart, aorta, vena cava, pulmonary vein, everything. So surgery says there's no way you can take this out on block. So we did neoadjuvant therapy with doxorubicin dacarbazine, which is actually what I use first line for leiomyosarcoma. If I want a response, and she shrunk really well after 3 cycles, and then continuing on for more cycles after 6 cycles, more shrinkage. And then she ended up getting radiation therapy. She got 8 cycles of doxorubicin dacarbazine with significant shrinkage in the mass, got consolidation radiation therapy, and is continuing on single agent dacarbazine. I just saw her a few weeks ago, and she's doing well.
So what are the questions you have about this case?
So I think the first thing is, what is first-line therapy for metastatic soft tissue sarcoma?
And how about in this case, and any thoughts about this case?
Well, again, Dr. Bowie knows what he's doing. I would say for the vast majority of patients with soft tissue sarcomas, if the disease burden is low and the patient is minimally or asymptomatic, first-line therapy is single-agent doxorubicin. I will consider an anthracycline combination, doxorubicin in combination with ifosfamide, doxorubicin in combination with dacarbazine, if the burden of disease is high, if there's a pending visceral crisis, or if there's a significant symptom burden. In this particular case, based on the imaging, I completely agree with an anthracycline combination, and I completely agree with doxorubicin dacarbazine. Historically, everyone would get doxorubicin ifosfamide, but we've actually learned that for extrauterine leiomyosarcomas, that ifosfamide actually doesn't provide much benefit. So for extrauterine leiomyosarcomas, it's dacarbazine with doxorubicin, not ifosfamide. So I completely agree with Dr. Bowie.
So I'll see if we can slip in a little bit of gist here. This is a patient of Dr. Boy also, 44-year-old man. Here's the case.
44-year-old man presented with shortness of breath to the ER, found to have a hemoglobin of 4.2. EGD colon capsule endoscopy showed a submucosal mass in the small bowel. CT chest and pelvis showed a multilobulated mass inseparable from the pelvic small bowel. Got a biopsy, 7-centimeter mass showing a GIST, started imatinib at 400 milligrams. It was stable, so they resected it, showing an 8.5 centimeter tumor with no mitotic rate. NGS actually showed a KIT exon 9 mutation. So he started on double dose imatinib, 400 milligrams BID. This is just a couple months ago, and he's still in remission. The first question is, what are the indications for adjuvant imatinib? They use the numbers 5 and 10. So if the tumor size and the mitotic rate is both over 5, then you would give imatinib because it seems to decrease your risk of local recurrence because the recurrence risk is high enough. Or if the tumor size or the mitotic rate, so this is the or. So if 10 or 10, then you would give it. His is 8.5, so it's less than 10, but it's more than 5, but the mitotic rate is less than 5. So in this case, you would consider not giving it. The next question is, how long do we give it for? So that was the initial CT before starting imatinib, single dose, and then after that, it was about the same size, didn't shrink at all. That just shows to show you that we should have doubled the dose because this mutation is resistant to imatinib in general. So if knowing that information up front, it would have been helpful to shrink the tumor more.
So you probably spent about 20 minutes talking about the case, but bottom line, any thoughts?
Well, I'll just mention a couple comments quickly. So at resection, the comment was that the mitotic rate was 0. In my opinion, that is hard to interpret because the patient had received neoadjuvant imatinib, which could suppress the mitotic rate. So for a tumor that was 8.5 centimeters in size with a mitotic rate of 0, but had received neoadjuvant imatinib, I'm not sure I would have confidence in saying that they don't need adjuvant therapy. In fact, I would make the argument that if you don't have a mitotic rate prior to starting therapy, I actually then assume that it's high, and I would have considered adjuvant therapy even in the setting of a mitotic rate of 0.
Interesting. So we had a case in the chat room, again, a little bit outside our field, but it sounds like this person maybe could use some input. This is Zeolin. Malignant giant cell tumor, T9, a 30-year-old woman, G3 for V and H383 mutation, resected June 2022, no Mets. Recurred May 2023 locally in the setting of second trimester pregnancy. Patient wants to keep the baby, had resection in the second trimester, delivered the baby, and now about to start RT, except the CT scan shows pulmonary Mets. So, question mark, systemic treatment options, chemo, Doxil, cis, any role of denosumab?
So just make sure I understand the diagnosis. It's a giant cell tumor of bone.
Seems like it.
Okay. So for giant cell tumor of bone, the only FDA approved therapy currently is denosumab. And that is what I would consider in this case.
Do you see objective responses to it?
Absolutely. Absolutely.
Interesting. So I think we actually had a patient who's on denosumab, another giant cell tumor. This is from Marzina. Young patient, locally advanced giant cell tumor of the spine, stable for several years on denosumab, now presents with multiple lung nodules consistent with metastatic disease, pulmonary symptoms. What comes after denosumab, assuming she gets biopsied?
Yeah, that now is a challenge. There is some historical data for interferon. In fact, prior to denosumab, we would do interferon. But that would be a challenging situation. I don't have an easy answer for that. Conventional chemotherapy does not typically work in this disease. So I think we're caught between a rock and a hard place. I certainly would look at clinical trial options.
All right, I'm going to see if I can squeeze one more GIST case in here. I know that's certainly not an uncommon situation, so we want to provide a little bit of input as well. This is a 65-year-old man, a patient of Dr. Thomas.
This is a patient of mine. Very challenging case in that this patient had tolerated his imatinib for close to a year and then had a short break. He was lost to follow-up during the pandemic. And then when he returned and we restarted him, all of a sudden his transaminases went up. He does not consume alcohol. The only other factor was that he was on the simvastatin. I'm not sure if that was playing a role. So I would love to hear from the expert, because imatinib is our most active drug in this disease, would they have continued it and pressed on for the 3 years? His transaminases rose into the 200 level, which was concerning to me. And then we watched him for a couple of years, and then he has small volume but multifocal peritoneal disease. And I started him on sunitinib, but I'm thinking in the future, if he recurs, what other treatments would be recommended?
Any thoughts?
Well, the first thing that I'm struck by is the statement here on this slide that says there's no actionable mutations by NGS. That causes significant pause for me because we use imatinib, sunitinib, regorafenib, ripretinib, which are the current sort of first through fourth line therapies for KIT and PDGFR mutant positive disease. If there are no KIT or PDGFR mutations, I don't think any of those therapies are actually going to provide benefit. So I'm a little puzzled about that. So I'd want to make sure that the diagnosis is correct. And if this is a wild type GIST, meaning no KIT or PDGFR, the question then is it an SDH deficient GIST? Is it an NF1 associated GIST? Is it an NTRK GIST? Some of those things, if not all of them, should have been captured by NGS. So I'm a little puzzled by that. Assuming that there is a KIT and or PDGFR mutant positive disease, I would reconsider challenge with imatinib. I would start at 100 milligrams, which is the lowest dose. If they get in trouble on that, well, then you've proven that they can't tolerate it. But certainly sunitinib in the second line, regorafenib in the third line, ripretinib in the fourth line would be the sort of sequential order. But I go back to the statement there where it says no actionable mutations. I'm assuming that means no additional actionable mutations on top of perhaps a primary mutation that just wasn't shared with us.
So very interesting. So thanks so much, Dr. Riedel, for working with us today and sharing your experience and knowledge. Audience, thank you for attending. Come on back on Thursday. We've got a lot to talk about with HCC. Be safe, stay well, have a great night. Thanks so much, Rich.
Thank you. Bye-bye.